Yeah, I'll post them, Gabby. I just gotta make them public for you guys. Okay, you're good. Okay, anisocoria for the abnormal pupil. Okay, let me just clear the text. So what you're trying to do here, let me just fix this actually. Okay, we're good there. Okay. So in this first picture, what you're looking at is a normal eye. So we have right eye, left eye. In a dark room, both eyes will be dilated because it's a dark room. Let more light in, they both can be dilated. You put a light source on one eye, you get the consensual response on the other side, light source on the other side, and so on and so forth. So this is a normal response. In this one, in B, the small pupil is the abnormal one. So I'm telling you already, it's the bad one. So as you look at them in the dark, the good eye is dilated like it's supposed to be because it's in a dimly lit room. Eye needs to dilate, but the right eye, because it's damaged, stays constricted. When you put a light source in the eye, it goes a little bit more constricted, so you can see the diameter of the pupil from top to bottom. It does change a little bit. And then you get the consensual response on the opposite eye. You still get a consensual response here because it already is constricted, so it'll give you the appearance that it is constricted. When you do near target, it resolves and it gets better. So with the accommodation, the pupil does respond, but not to light. In C, the large pupil is the abnormal one. So in a dark room, they're both going to look normal because you're in a dark room, dimly lit. Again, both should be dilated, and they both are. But this is the damaged eye. Now we put a light source in that eye, and there is no constriction. Because it's damaged, it's not going to constrict. Therefore, and then you get the consensual response on that side. You put the light source on the left side, and there is no consensual response on the right. So that's how you know that the right is damaged in this case. So in a dark room, you start off there. If they're both dilated, you still don't know which one's affected. Do your light test and figure it out. In this case, when you put them in the dark room, Immediately you see one eye is constricted compared to the other. That gives you the clue right there that that's the affected eye, because in a dark room it should dilate and it's constricted. So I hope that answers your question about the anisocoria. Cara, I think you missed that class also, so maybe I think you were back for that one. Next is stroke symptoms and blood supply. Okay. So the biggest thing to remember for this one okay. Start here first. Actually, let me have a better picture. I guess not. Okay. So the big thing is know the territories. So we have anterior cerebral, middle cerebral, posterior cerebral. So your anterior cerebral, I think I don't have a better picture in this one. I guess I don't. Remember in the homunculus, the way that's set up, the anterior cerebral artery, let me just add a page. Okay. Anterior cerebral artery is going to be, legs. Middle cerebral artery is going to be face and arms. PCA goes to the occipital. So think visual problems. And that's one way to figure out what artery has been affected. Same thing you do with EKGs. The other thing you got to do is this right versus left. So figure out first in the question what side of the body is being affected by this stroke. Then you know it's the opposite side that is you're going to have the motor or sensory issues with. And then figure out what body part are they having problems with. The legs, it's going to be, ACA. If it's your face and arms, middle cerebral artery, anything to do with visual changes, PCA from there. Okay, so that's pretty much the gist of all that. Okay. Next question, simple versus partial seizures. Where's my summary slide? Okay. So looking at seizures, simple versus complex, as far as they're all considered partial seizures. Partial only affects one part of the brain, just one side. If it does affect both, it's going to generalize and you have a full loss of consciousness, and it goes to one of these. Simple has no loss of consciousness at all. They can evolve into the generalized one. Complex has altered consciousness, loss of consciousness, just altered consciousness. So you're going to have some weird things going on. Okay, so simple partial seizures, no loss of consciousness. Isolated tonic or clonic activity of a limb, so they're going to have some jerking, but they're going to be awake. no issues. Some sensory issues, and maybe a march where it'll start in the wrist and then it works its way up. When you get to, this is the answer to the other question too. Complex has an aura, so they have a little bit of abnormality of sensation, perception, this impaired loss of consciousness, maybe a little bit of amnesia. They won't remember the event itself. These automatisms we'll talk about in a second. That answers the next question. So Gabby, I hope that answers regard. Okay, so simple versus complex, still a partial seizure because it's only one side. Generalized versus complex. The entire brain is affected, and these are the examples of a generalized seizure where the entire brain has been affected by whatever's going on. So these are examples. So automatisms could be like lip smacking, hand moving, flailing, but in a absence seizure, they have total, the daydreaming is a petit mal seizure. So they're going to totally just stare off into space like they're just daydreaming, looking at nothing. But they are totally out of it until you can shake them, hey, wake up, wake up. And until they come out of it, then they'll be okay. But they will have a total loss of consciousness during that daydreaming. Next question about BP control with strokes. Okay. So in a hemorrhagic stroke, okay, intracerebral hemorrhage, subarachnoid hemorrhage. Subarachnoid, you want to keep it below 160. With an intracerebral hemorrhage, 150 to 220, kind of watch, kind of leave them alone. When they start getting over 220, then you want to bring it down, but not so fast because you want to keep that perfusion pressure going. With both the hemorrhagic and the ischemic ones, you don't want to drop the blood pressure too much because then they're going to get that perfusion pressure to keep that blood pushing to get through that occlusion. For the ischemic, 220 over 120 is the cutoff. When they start getting higher than that, then you want to give like labetalol IV to help bring that pressure down. So the key thing is 220 over 120 for ischemic, 220 again for these intracerebral hemorrhages, but on the subarachnoids it's less than, keep it less than 160. You want to cause any more cerebral edema or intracerebral pressure, so keep that pressure down. Question about vision loss. So the carotid artery, the reason why is because of the way the carotid artery does it. Let me get to that one page. Okay. Okay. So with carotid artery syndrome, you're blocking pretty much all that going away. So everything that's going up from the carotid up on the same side is being fed the retina and all that stuff on the eye that's feeding the actual eye structure as it is on the same side of the carotid. So you're not really having any issues with your cranial nerves. The issue is just the retina being perfused with blood comes from all these structures in here that gets there, and when you block the carotid, everything upstream from that is going to be affected, and it's going to be ipsilateral vision loss with the carotid artery occlusion. So they get this ipsilateral monocular vision loss, contralateral arm, leg, because of the opposite part of the brain that's being fed. It's controlling the motor system on the other side. So I hope that answered your question about that one, Sarah. I'll be right back. I'll get some water. See anything else? Anything else? Okay, tremors. Okay. Okay, so we have different types of tremors. Postural tremors is an action tremor during sustained posture. So this is, like I said, sitting in a chair and you start rocking. You're sitting in a sustained position. All your postural muscles are contracted and toned to have you sit up straight. And then you get tired of it, or not tired of it, but you have this tremor and you start having this rhythmic oscillatory tremor, and that's just shaking in your seat and stuff like that. That's an example, but they're benign essential tremors. The intentional tremor is only there during planned voluntary movement. So when you say like, okay, they're sitting there at rest and they're not doing anything, there's no tremor at rest, you say, do your finger to nose and point to my finger. As they do it, they get the tremor. So that's an intentional tremor, not present at rest, and there may be a cerebellar lesion for that one. And then there's a resting tremor when the limb is at rest and there's still this oscillatory movement going on. So that's the 3 different types of tremors. Then you have chorea, irregular muscle jerks. They're involuntary, unpredictable. Has these skip lesions, so it goes from one body part to another, and it bounces around. So it's hemibolismus. This one got cut out. So it's unilateral chorea. That's all it is, just on one side of the body. Athetosis is that sinewy movement, flow like a snake. And the wrist just keeps twisting and contorting, and pronation and supination and flexion and so forth. But it's not jerky as with the other types of movements are. This is the only one that's kind of flow and moves around. So that's athetosis, not present during sleep. If they have a prolonged posture dystonia, so in that question we had over the Kahoot, the patient had acute torticollis due to this acute dystonia. So that's the difference when they're contracted and then they stay contracted. Dystonia is just a sustained muscle contraction, not present during sleep, enhanced with voluntary activity. They can have a focal dystonia, so they'll have issues with the head and neck posturing, which is the example I gave in the class. Generalized dystonia can be caused by a cerebral palsy. Treatments, your anticholinergics, benzotropine, cogentin, and then obviously your botulinum is there too. Tardive dyskinesia, the lip smacking, lips moving, tongue protruding, all that stuff. Tardive dyskinesia, usually a side effect of drugs, most commonly Haldol, but it's just a side effect of the drug usually. Myoclonus, twitch-like movement, contraction, but it's just a twitch, single twitch usually. Some sensory stimulation can do it as well. So if you ever like someone touches you and you twitch and your whole body jerks, it's an example of a myoclonus. The nocturnal myoclonus will wake you up. Epileptic myoclonus is during seizures. Pathologic myoclonus, movements brought about due to epilepsy or the head injury. And asterixis is a negative myoclonus, and you see that with liver failure patients. They have that liver flap. And you hold their stop like this, and their hand will start flapping. That's due to liver failure. Tics, jerky, quality coordinated movements, small muscle groups, so like in the eyes they'll twitch, maybe the lips, they'll have these constant little tics. Same pattern, same muscle groups. Tourette's is an example of it. Tics worsen with stress and disappear during sleep. Transient simple tics are common in children, just resolve on their own. Chronic simple tics, again, usually more in childhood. Reassurance, a lot of these tics just reassure that it's not a major problem as you go away as they get older with the kids. But if you talk about it, then they get self-conscious about it, and they can develop like complexes and stuff like that about it. And Tourette's is chronic motor vocal tics. So with these abnormal movements, always talk about the age. So whenever you read these questions, the age matters. And, when you're reading these questions, they give you a clue as far as what diseases they could be and what diseases they can't be based off of, the age of the patient and whatnot. Here's that Haldol again we were talking about before. Can cause these issues as well. Family history one, special, and then we went through it more in detail. But remember your treatments. Tremors, beta blockers are good. You want to start off with Klonopin, that's pretty strong. And you can go over the surgeries later on if the tremor gets where it affects their daily activities of daily living. Acute dystonic reactions. These are the ones that can cause it. They're drug-induced. So Phenergan, Compazine, here's your Haldol, can cause acute dystonic reactions. Cocaine, TCAs, lithium, anticonvulsants can also cause it as well. Different, how it affects the muscles in the face, the larynx, eyes, mouth, lips. But Benadryl is the main one to give. You can also give cogentin as well to help with these acute dystonic reactions. Remember your mnemonic: akinesia, bradykinesia, rigidity, tremor, postural instability, TRAP. I didn't do it in order, but you know what I mean. For your Parkinson's patients. Cranial nerves. Remember Horner syndrome, unilateral, ptosis, meiosis, and hydrosis on the same page. Wait a minute, why can't you see this? There we go. So your ptosis, meiosis, and hydrosis on the same face. The cocaine drop test is the one that you would use to confirm Horner's. Your evaluation, CT imaging, lung tumors are possible there. So remember this one as far as looking at it between a cranial nerve 3 palsy versus Horner syndrome. Okay. Argyll-Robertson pupil does not react to light, but it'll accommodate. So as you do your accommodation, it'll react. Your 80s pupil, there's your algorithm. One straightforward. Tic de la Rue, trigeminal neuralgia, just again going through the way they're going to complain about the exquisite pain and, over the distribution of the trigeminal nerve. A lot of these neuro drugs are the same throughout the entire thing, so there's not that many you have to remember. Bell's palsy, remember HSV infection. Oral pain is a big one. Numbness, hyperacusis. Impaired taste, because that's the facial nerve's job, is to give you the sensation of taste. Prednisone, burst and taper, and acyclovir. And don't forget about your pain management, because they're going to be in a lot of pain. And gabapentin is the big one to give for that one, for pain. Ramsey Hunt in the ear. Also any distribution. Vertigo and dizziness, we did this already in the other section. Make sure you know the difference between conductive hearing loss and sensory neural. And then obviously we know what our cranial nerves do, because you've been doing it since your summer 1 when you learned PD. So make sure you know which way the uvula goes. Shifts to the normal side. So when you're doing your, say, you're looking for uvula being midline. If it moves to the right, the right side is normal. The left side has the issue. The tongue is the opposite. It's going to deviate towards the weak side. So if it goes towards the right, the weak side is the right. If it goes towards the left, the weak side is the left. The uvula goes to the strong side. The tongue, cranial nerve 12, goes to the weak side. So remember those. Taste and whatnot. Okay, don't forget about delirium versus dementia and the differences between all those. delirium is the level of consciousness. Dementia is the content, where they're still alert and everything, normal level of consciousness, they're just not making sense, or they're confused because of the advanced dementia. Just remember the mnemonic delirium for causes of delirium. So when you're going through your differentials and thinking about, is this delirium or dementia, looking at what the underlying causes. Exacerbated dementia can cause delirium in acute phases. Obviously, they're going to be confused, but towards the end in dementia, they can have some delirium as well. Infections will be the big one you're going to see, especially in the elderly with UTIs. They're going to come in with acute confusion all the time, and it's just a urosepsis from the UTI. So that happens a lot. Remember, always check your glucoses, because even high or low, they can cause mimics of delirium, strokes, seizures, all due to glucose. So always don't forget to check your glucoses. Okay, don't forget for meningitis, go through, know your triad of symptoms, what they present with. Know your two special tests, Kernig's and Brzezinski's. Know the differences. Know the lumbar puncture analysis. What are you going to see with meningitis? That was a Kahoot question. Okay, know obviously which one is the most common culprit now. This is more CSF analysis between bacterial meningitis, viral. Basically, the white blood cells will be a lot different, of course. Glucose is going to be majorly different, but just think about why these things change. You don't have to memorize these things. It'll just make sense as far as why they present with these labs. Okay, so viral, again, most common. Herpes, varicella, zoster, chickenpox, mumps, HIV are all causes. Here's your CSF for viral. Remember, the biggest thing with any type of meningitis, just give them antibiotics as soon as possible, because bacterial is the worst one, but you don't know which one you have, and it may not know for a little bit, so just get them going now. If it is viral later on, just add in some acyclovir to help with the viral part of it. Most of it's going to be symptom management. Some steroids to help reduce inflammation. Here's your encephalitis. Okay, most commonly viral, enterovirus, fecal oral. Here's your HSV, ZVC, or VZV. Yeah, so we'll go over headaches. Okay, so acute causes of headaches. Trauma is going to be the biggest one due to your subarachnoid hemorrhages is the big one. They're going to have Koenig sign as well for this one due to the increased volume in the CSF. Sudden onset thunderclap headache are the big ones. Non-focal Neuro exam, you're not going to see much on it. With a subarachnoid hemorrhage. Head CT without contrast is always the first thing you do. Looking for bleeds. And then if you can do an MRI angiography when the patient's stable. If the CT is negative and you still suspect that they have a subarachnoid, do a CSF, do a lumbar puncture. And you're looking for that xanthochromia, a tinge of yellowish, pinkish fluid. Subarachnoids, this one, prevent elevated, remember we talked about before with a BP, 160 for that one. You need to get that pressure down or they're going to keep bleeding into that subarachnoid space. Again, avoids aspirin for these patients. Meningitis, again, will cause headache, pain. We went through that already. Subdural hematoma is usually due to in elderly people, due to veins breaking. This is your intracranial hematoma, traumatic brain injury. So these are subdurals. Remember, we have the veins that are bridging veins, and they all break, and the veins just ooze blood, and it takes a little bit of time. So you get this hematoma buildup, and it's severe enough. You get some pressure on the brain, and obviously, depending on what parts of the brain are being squeezed, you get those changes there. Subdural hematomas also have that lucid phase where they'll be fine for a little bit, and then a little bit, like about an hour, 2 hours, 3 hours later, they crash, and they can obviously paralyzation or even death. So that lucid period again, subarachnoid, subdural, I'm sorry. Treatment, surgical decompression. Just do a borehole, go in there, and actually pull the skull off, and you can see the hematomas there. And then you can remove them, suck them out, and get rid of the blood that's there, that's pooling. Subacute tumors will do it. Giant cell arteritis. Idiopathic intracranial hypertension. This is that pseudotumor cerebri we talked about in the Kahoot. Some drugs can cause those as well, but classically middle-aged, obese female will do it, limited to a few months. Symptoms they're going to have, obviously the big one is going to be papilledema, elevated CSF pressure, and then you just get rid of that, do a VP shunt. Postherpetic neuralgia will also cause it, again, just shingles, very, very painful. Trigeminal neuralgia, and here we go with our headaches. So always find out, is it similar to previous headaches, and what did they do the last time? Your migraines, at first, increase serotonin, that causes vasoconstriction, and that gives the aura phase, or that hypoxia, or due to hypoxia, that gives an aura phase. Then you get a rebound vasodilation, and that actually causes the actual headache itself. That's usually due to a drop in serotonin levels with these migraines. Remember the pound mnemonic, we went through that. Know the differentiation between with an aura and without an aura. With an aura is a classic migraine. Without an aura is a common migraine. Exam is going to be basically normal outside of the attack, but then during the attack, obviously you're going to have the photophobia, want to be in a dark room, quiet, and do their own thing. Acetaminophen, your normal NSAIDs, then you can get into your 5-HT agonists. Sumatriptan is the big one. Works really well if you start it early on. Causes vasoconstriction of the carotid arterial tree. So we're constricting the vessels going into the brain, and that's going to reduce the headache because it's vasodilation that causes the headache to occur. And then you have these ergot preparations as well. So those are the migraines ones. Now, if they have recurrent migraines, you want to stop them from happening, then you give them a prophylaxis. And beta blockers, propranolol is very, very good for that. Also, you can give amitriptyline and get your headache diaries going so you know what are the triggers and what caused them to have the migraines. If they can figure out what caused it. Drug rebound headache, just think of people stopping caffeine when they started drinking it when you start school, you start drinking caffeine like crazy. Then you stop it and you get a rebound headache. That's just due to the stopping of the meds or the caffeine. And you can give ergot prep or sumatriptan depending on how bad the headache is. Cluster headaches. Let me clear the page here. Unilateral may start as a burning sensation over the nose or pressure behind the eye. So that periorbital. So we have that in the Kahoot. The guy had the periorbital pain. That's where it comes on. That's the cluster headache. Commonly at night, may wake them up. Lacrimation and tearing on the same side. So again, they may have Horner's, but the key is no ptosis in this one. Or they have it in Horner's. Lasts a few seconds to a couple of hours. This is in more males than females, and the big treatment is 100% O2 for that one. You can give some of the other ones. There is some prophylaxis as well, some calcium channel blockers. Your verapamil is good for cluster headaches for prophylaxis, not to stop it though. Tension headache. This is band-like. Okay. Yeah, they're band-like right there. 30 minutes, may last a little bit longer. May, last more than a bunch of days too. They may have that headache lasting a long time. Typically bilateral forehead, temples, and occiput. No photophobia, nausea, vomiting, or visual changes. They just have this headache, and between the attacks, they're okay. Treatment, simple analgesics work. NSAIDs, you always try the NSAIDs first. That's the easiest thing. And then from there, if it doesn't work, then you can up it from there. Tension versus migraine, post-traumatic headache, this is concussion. What else is there? And these are just your non-neurological diseases that can also cause headaches as well. That's imaging. Okay, let me go to next question is about Huntington's disease. Okay, a couple of big things to remember about Huntington's disease. It's genetic, so it's inherited. They get chorea. There's a psychiatric symptom part of it, and cognitive deterioration are three major parts. That they're going to have dementia, and the psych disturbances may precede the movement disorders. So they may have the psych disturbances first before they have any movement problems. Because of chromosome 4, again, the caudate nucleus atrophies, basically getting increased levels of dopamine. Develops after age 30. They don't last very long, unfortunately. These are the early signs and symptoms. Again, the psychiatric and the motor stuff happens later. Here's your depression, anxiety, emotional ability, and so forth. Late signs are your big movement issues now. So the chorea happens, bladder, bowel incontinence, dysphagia, all that other stuff. Treatment, there's one coming soon, but as far as now and in your exam, there's no treatment. But again, the biggest thing are symptom management, taking care of all the symptoms for that patient. And then you see here that the putamen is atrophied in these patients with Huntington's disease. Sydenham's chorea, just remember they're going to have some sort of rheumatic fever as a child or recent history of rheumatic fever. And then obviously get rid of the strep. So that's it for me lecturing you guys officially. Now I'm just a guest lecturer in other people's classes because I have to go back to physio in the summer. Dementias. Okay. Alzheimer's disease is the most common one. Those are the ones we've always talked about. You know, they have the Louis tau tangles, the beta amyloid plaques, those things and so forth. Then you have dementia with Lewy bodies. They're inclusions, and the other big thing with them is they have hallucinations. That's the big key one there. Vascular multi-infarct dementia. Those are the lacunar infarcts. Stepwise progression. Every time they have a drop, they have a new infarct. Frontotemporal dementia, we really didn't go over very much. But obviously it's going to affect the frontal and the temporal lobes. And then Parkinson's, obviously with dementia, they do have a link. They are connected a little bit. What else is important here with Alzheimer's? So forgetfulness is the most common one, but they're going to have other problems later on, disorientation at time. And so for 5 to 20 years, restless, agitated at first, and then they neglect bathing, dressing, and eating. So that's where that inhibition comes into play. Early on, non-focal neuro exam, just short-term memory problems, get your MMSCs going. Some issues with walking. Later, some language, cognitive decline, and then later on, you start getting some real progression of the disease. Social graces are lost. Psychiatric issues, psych issues, extrapyramidal rigidity. Okay, so there's that trap symptoms again. Treatment, Aricept, donepezil, the big one. Exelon is a patch, which is good. Remember, side effects, always check LFTs before you start a lot of these drugs, and a CBC, just to make sure they're not dropping and causing any issues with those. Namenda is another one, but I mean, you know that stuff. Dementia with Lewy bodies, they have these inclusions. Those are the inclusions right there going in there. But again, the key is this hallucinations and delusions. But again, they're going to have Parkinsonian features. They don't actually have Parkinson's, but it's Parkinson features. And then don't forget your trap symptoms. Lacunar infarcts, the stepwise progression, hypertension control is the big one. Pseudodementia, depression. So don't forget that is in there. Distinguishing dementia versus depression is a big one. You guys, guys start getting into behavioral health, you'll get into that a lot more. You'll see that everything overlaps. That's pretty much it. And then obviously there's a good summary slide at the end here for delirium versus dementia. anything else majorly important. This is a pretty straightforward section, so these aren't that bad. What else was seizures? So a lot of the doesn't matter. The only one that's different for the seizures as far as treatment is the absence petit mal seizure. They take the Zoran. But for their first time they have a seizure and they show up, we gotta get them go home with the medication. These are the big ones they're gonna start off with as well. These are great secondary drugs to add on, and even Keppra is a good one to start off at first. But the ones that are bolded are the big ones that they're going to use for treatment of seizures. So here's that absence seizure. It's just the ethosuximide, the Zoran. Myoclonic does really well with Depakote and Klonopin. But the generalized tonic-clonic or partial focal seizures do well with the other ones. As far as treatments go, again, get a journal. See what happened before, whenever a seizure happens, kind of look back and see what they're doing beforehand if they can remember. Always remember this one. Most common reason for getting a seizure on medication is not taking the medication. So always ask, make sure they're taking their medications. Cranial nerve, big one here. Also, don't forget cranial nerve 3 is a big one to know the differences with because of the diabetic pupil. Okay. So remember with a cranial nerve 3 palsy, first of all, anyone with a new onset cranial nerve 3 palsy must be ruled out for, wait a minute, you can't even see this. Hang on. There we are. So cranial nerve 3 palsies, diplopia, ptosis, fixed position of eye, downward and outward, dilation of the pupil. So the dilation of the pupil is important to remember. Any new onset, rule out cerebral artery aneurysm first before anything else. The big thing is though, here it is. If the pupil is spared, it's diabetes related vascular infarction of cranial nerve 3. So, cranial nerve 3, if pupil is dilated, it's a cranial nerve 3 palsy. If the pupil is spared, it's cranial nerve 3 palsy due to diabetes. Still, rule out aneurysm first. Doesn't matter if the pupil's spared or not. Cranial nerve 3 palsy, you gotta get an MRI to rule out that aneurysm. Okay, next is about posterior circulation strokes. Okay. So posterior circulation is the posterior cerebral artery occlusion and vertebrobasilar artery occlusion. If the infarction includes the occipital lobe, you're going to have visual problems, memory issues, visual hallucinations, some sensory loss, athetosis due to the posterior cerebral artery occlusion. If the infarct is in the brainstem due to this posterior circulation, then you're going to have Weber syndrome, cranial nerve 3 palsy, hemiplegia, hemiparesis, eye movement issues, ataxia. So again, posterior cerebral artery, nothing to do with movement of the body, but it's your vision and so forth is a big one. With the vertebrobasilar artery occlusion, again, vision problems, some vertigo, nausea issues there, drop attacks with no loss of consciousness. So we learned about the atonic seizure where they just like drop, but they don't lose consciousness like they do with the atonic seizure. This one, they drop, but they're still awake though. They have these drop attacks, or off arms will just drop, whatever. But again, it can cause cranial neuropathies, eye movement problems, paralysis, sensory loss, and even go to a coma. Subclavian steal is the last thing that we talked about, where it mimics a posterior cerebral stroke because you're pulling blood from the vertebral arteries. So with a subclavian steal, because we have a blockage there, blood can't get to the left arm. So we have to get it from somewhere. So what it does, if look at the arrow is pulling the blood down from the vertebral artery, which, remember, the circulation from the carotids going up, it all mixes up at the top in the brain. So it pulls the blood back down. So it mimics a stroke because you're pulling the blood from the circulation. So that's the other, it's not a real posterior stroke, it just mimics one. The big thing you'll see is the blood pressure changes on both sides, and then treatment, just stent and just open up the blockage and they'll go away. And that's that one for posterior. Majorly important here. Okay, so this one, you will have a question dealing with TPA criteria. There'll be a scenario. So obviously I'm going to pick the major ones. So blood pressure being high, active bleeding, platelets being low, heparin received recently, high INR, head trauma 3 months. You know, those are the big ones. Recent subarachnoid. These all make sense as far as why would you not want to give someone a blood thinner that's going to be really, really strong blood thinner that's going to make things a lot worse. So that's that one. And you want to go over anterior cerebral ones. Okay. Anterior cerebral artery territory, emboli, also a subarachnoid, can also call it is an anterior circulation issue. Lower limb weakness, because the anterior cerebral artery feeds the homunculus part for the motor of the lower extremities. And apraxia, they can't complete a motor task. So anterior cerebral artery occlusion, contralateral paralysis of a leg over the arm, sensory loss, again, they may have that, apraxic gait, contralateral grasp reflex and sucking reflex, and abulia, loss of spontaneity and lack of concern. So that's the big thing with the anterior cerebral circulation. You also have the carotid arteries as you go lower, and obviously they're going to have more of a territory. So just think if you have a blockage here, everything upstream is going to be blocked as well. So you're going to have a bigger territory loss. That's why you have a lot bigger things that can go wrong with these anterior cerebral circulations, because it really does include 3 major areas. The higher you go up into, here's your middle cerebral artery. You know, if you block that out, only those things distal to those things, to that blockage will have problems. But when the blockage is down here in the carotids, everything upstream is going to have an issue as well. And that's why they have such bigger problems, because it's a bigger territory of the brain that's now having lack of perfusion. Anything else major here? So I would also make sure this one as well. Make sure you understand that if they are complaining and all they're complaining of is aphasia, agraphia, acalcula, they can't, do math and they can't speak and they have issues, that's going to be their dominant hemisphere. If they're complaining of neglect, confusion, it might be their non-dominant hemisphere that got affected. And then they're going to have a gaze deviation towards the infarcted hemisphere as well, with a middle cerebral. Middle cerebral arteries are also the big culprits when it comes to AFib. They like to go right to that middle cerebral artery as well. So they get a lot of facial and arm weakness with these AFib strokes because it goes right to the middle cerebral artery. And these are your 2 examples of posterior circulation. I will give reviews also before those endo exams as well, if you guys need it, but it's up to you guys. And then on Thursday, you guys get to put all this stuff to practice when we get our Neuro lab on Thursday. I don't think there was much else really that we haven't really gone through. Make sure you know these things too. The criteria for your 1, 2, 3, 4, 5. Criteria for brain death as well. But again, they make sense. You think about it, as you go through them, they're not going to regain those functions. Um, I gotta go for Kansas City, unfortunately, because I'm a Giants fan. I can't see the Eagles do anything good, especially with Sankar there. I gotta go for the three-peat for Kansas City. Okay, so Sono, did you want that question or no? So, Sana, your question got retracted, but what I'm trying to get through here is not everyone is going to present with a stroke. Not everyone's going to present with motor problems or sensory problems. But basically, if they come in and you do all your exam and you do everything and you notice that they can't do basic math, they can't spell things, they can't speak very well, those are the only symptoms that they're having. You can't attribute not knowing a object or not being able to speak or not do math to a side of the brain. Because if it's like my right hand is down, that's very easy to look like, okay, the left side's down. But when they come in with these type of complaints, you don't know what side of the brain is being affected. So what this is telling you here is that if they come in complaining of a calcula, alexia, where they can't do math, they can't spell, they can't speak, it's going to be their dominant hemisphere of the brain. And how do you know that? Ask what hand they write with. If they're right-handed, it's a left dominant brain for that person. You know that the left side is having that stroke. If they come in and they're complaining of neglect, apraxia, they're confused, those are the only really issues that they're having. They might be having a stroke on the non-dominant hemisphere of their brain. So if they're right-handed, the right brain is their non-dominant, and then be having neglect, that hemispatial neglect where they don't, shave or comb their hair, brush their teeth on one side of their body. They only apply makeup on one side of the body. They may be having a non-dominant hemisphere in CVA. It just clues to help you figure out where the issue is coming from. So I hope that helped Sana with that one. Remember about TIAs, what they mean, things to watch out for with treatment, ABCD rule. Remember, talk about primary and secondary prevention. Primary is preventing that first stroke from happening. Secondary is preventing the second one from happening. So your CHADS 2 VAS score. So here's your subdural hematoma, essentially. Intracerebral hemorrhage. Subarachnoids, what causes them. AVMs, intracerebral hemorrhage again. What they do. Here's your BP control again. Different ways to surgery. Correct it. Again, high mortality. You don't need to calculate the ABCDs. Just understand what they're there for, as far as your evaluation and treatment of the patient. Any last minute questions? If not, I'm going to end the stream. I know this stuff is pretty easy compared to what we've done in the past. I know we were going right till 8:30 and some of the other subjects. So. Okay, I guess everyone's good. So I'll see you all bright and early tomorrow morning. Have a great night. And I will see you all in the morning for your last exam. Good luck. See you all tomorrow.